Hello, I'm Mary Ito, and welcome to the CRAM podcast. A number of people I know, actually quite a few when I come to think of it, they've sought counseling, psychotherapy, and it's been a huge help for some of them. And then for others, not so much, they tell me. And I know some folks who are interested in going for counseling, but they're not sure about what's involved, the cost, how often they have to go, and whether it really works. I thought it might be helpful if we looked at the different approaches to psychotherapy, why people go, what they can expect from a session, and what are the outcomes. Dr. Martin Drapeau is a clinical psychologist and professor of counseling psychology and psychiatry at McGill University, and he joins us this afternoon. Hi, nice to meet you, Martin.
Hi, Mary. Thanks for having me with you.
Well, let's get right to the $1 million question right off the bat. Does psychotherapy work?
Absolutely. It absolutely works. It's funny because I give conferences, I write papers about this, and every now and then I have colleagues who are physicians, general practitioners, who say, well, if psychotherapy works, how come we don't talk about it? And for some reason I keep saying, well, we've been talking about this for 40 years now. It's been demonstrated over and over and over again. It makes a huge difference in people's lives. The people who receive psychotherapy across the board, for example, if you look at cross conditions, definitely do much better, significantly better than people who don't receive psychotherapy. So that question has been asked many times. It's been answered many times. It definitely works. Now, don't forget that this is across the board, right? So it's when you fold all types of therapies and all types of conditions into one big data set. If you look at specifics, then there's nuances. Of course.
You know what? So then that also begs the question, why, if it's been proven for so long and there is all this evidence around it, why is there still so much skepticism?
I don't think it's so much I don't think that's what it is. I think there's the real reason is access. So, if you look at the health system in Ontario, Quebec, across Canada, basically, when it comes to a patient feeling depressed or anxious, they go see their GP. The GP, their services are covered by provincial health. In many cases, the psychologist or psychotherapist services are not covered by provincial health. So people have to pay out of pocket. And so when they go see their GP, what ends up happening is the GP says, well, you have two options. Either you pay out of pocket and you go see a therapist or a psychologist, or we put you on this endless wait list to access a psychologist in the public system. In Quebec here, we have the wait time is up to 2 years now to see a psychologist in the public sector. And Ontario is not far behind, right? Mm-hmm. So people have the choice. They either pay or they go with the option that's covered, which is medication. And that's what ends up happening. So I think it's really a matter of access and resources and putting the money where it needs to be put.
One thing I've wondered about with treatment as well, and I guess this would be true really of any relationship with a doctor, but specifically with a therapist, I think of the personal nature, right? The personal relationship that you have with your therapist. You're disclosing all these aspects about yourself that maybe you would tell nobody else.
Absolutely.
So is the relationship with the therapist as important as the treatment?
Yes, it is. This is a fascinating question because researchers have been fighting over this for, I'd say, 25, 30 years at least. So there was a time when we thought the only thing that mattered was the relationship. So if I can build a strong relationship, what we call a therapeutic alliance in our own words, a therapeutic alliance with our patient, then that should be therapeutic in and of itself, right? So that's what we thought for the longest time. Then we did some more research. We realized that's not the case. You actually need to do a little more than build that relationship. And then what's the content of that relationship? So the therapeutic alliance is broken down into subcomponents. There has to be an agreement between the patient and the therapist or the psychologist on goals, for example. So what are we trying to accomplish? There has to be an agreement on tasks, and there has to be that emotional reciprocal bond, right? Of, with respect and mutual appreciation. So you need the three components. If you have those three components, you're halfway there. Once you have that, then the technical component comes into play. So that's the second part, which is, it's not enough to have a strong therapeutic alliance. You also need to know what you're doing, at a technical level. Mm-hmm. So using the right techniques, the right strategies. For a while, we didn't think that matters. we now know for a fact that for some conditions, the technique actually matters more than the therapeutic alliance. So, for example, when you're treating anxiety disorders, there has to be an exposure component to it, which means exposing the person to the condition or situation they fear. If you don't have that, you can have the best relationship in the world. It's not going to have the type of outcome that you want. So you need both.
Okay.
So the consensus is basically that both the alliance and the technical component are essential but not sufficient conditions to lead to positive outcome. You need both.
You need both. Okay. So just before we get to that, I want to talk as well, though, from the patient's point of view or the client's point of view. What do you say? Do you say patient or client?
Say both.
Oh, okay.
Yeah, don't worry about that.
Okay. So, I mean, who, first of all, should go and see a psychologist or a therapist? Because I think, well, you know, we all have problems. I have problems. There are some parts of my personality I don't like. You know, maybe we carry around some baggage we don't like. I don't like some baggage. We have relationships that we don't like. I mean, these are things that probably affect many, many, many people, right? So how do we know, gee, you know, I think I really should see a therapist about this?
Well, those are all good reasons to see a therapist. The real question is what kind of suffering is involved. So does this lead to distress in yourself, for example, in family members, people around you? If that's the case, then it might be a good idea to see a therapist. The simple answer is really you see a therapist when you're not feeling right. Now, you mentioned this yourself. Anxiety is normal. Stress is normal. You know, having the blues, that's also normal. I have bad days. You have bad days. If it lasts a few days, that's fine. If it lasts a couple weeks, 3 weeks, then that's a different ballgame. Then it's probably time to seek services. Now, don't forget that one of the things that you have to keep in mind here, really, that's really important, is that the earlier you seek services, the earlier you treat when it comes to anxiety and depression, the better the outcome. So you don't want to wait 6 months or a year. You want to go as soon as possible. Well, you know, what's the worst that's going to happen? You're going to be told, well, it seems like it's normal, right? Come back if things get worse. But at least, you know, you're not going to have a situation where a diagnosis is missed.
Okay. And then what about, so yeah, that could cover a lot of people, I think. That can affect a lot of people. But can anyone benefit from psychotherapy, or are there certain mental health conditions that are resistant to benefit?
That's also an excellent question. It depends on what you're trying to accomplish. So, for example, if you think about psychosis or psychotic conditions, you do not treat psychosis with psychotherapy, right? You treat it with medication, for example. You can use psychotherapy to help the person cope with some of the symptoms. So that's slightly different. You're not trying to cure the person. You're trying to help the person cope with a condition that tends to be biological and medical. When it comes to other conditions, for most eating disorders, all anxiety disorders, psychotherapy is extremely effective for all anxiety disorders. That goes from specific phobia to generalized anxiety and so on and so forth. That's great to use. That's the first course of action. For mood disorders, that includes depression, first course of action as well, psychotherapy. There's perhaps one exception, dysthymia, which is a milder form of therapy that tends to be long-lasting. Psychotherapy doesn't tend to be as effective for that condition. Medication either, by the way. So it's a very difficult condition to treat that tends to be chronic. But for the others, the ones that we're usually confronted to, anxiety, you know, high levels of stress, eating conditions, relational problems, mood, depression, and so on and so forth, psychotherapy is definitely the way to go.
Okay. And so then when do drugs come into play here?
Yeah, well, drugs will come into play when there's a medical component. So, for example, I use the term loosely because, you know, everything is medical. Everything happens both in the body. So depression doesn't happen in your foot. Of course, it happens in your head and your brain and so on and so forth, right? So, depression is one of the situations where, for example, if you have milder forms or moderate forms of, or severity of, depression, psychotherapy is the way to go. There's no added benefit in general in using meds. For more severe forms of depression, so, you know, very, very severe forms of depression, then you should have a combination of both medication and psychotherapy. Now, don't forget, these are all, you might be familiar with the normal distribution, the curve, right? The bell curve. So this is populational data. What that means is that there's exceptions within this. So not everyone falls right on that middle line, which is the average. So some people might prefer medication, even if they have a milder form of depression. And if they prefer it, it's better to give them that medication because then you've just boosted the positive outcome. So
Oh, okay.
patient preferences really do matter. So, if a patient says, I want the blue pill, and you give them the red pill, you've just decreased the effect of the intervention. So it's the same with psychotherapy and medication when it comes to mood and disorders and anxiety disorders.
Really? Just because, well, I'm sure every drug has some kind of side effect, right?
Mm-hmm.
Well, as maybe psychotherapy has a side effect too. But, does the patient know all that? Because maybe they prefer the blue pill, right?
Mm-hmm.
But the blue pill comes with maybe more serious side effects than the red pill that the doctor wants to prescribe. So is it really always a case that whatever the patient prefers is best?
No, absolutely not. And that's where informed consent comes into play, right? So informed consent, if you come to see me, for example, my job is to say, well, this is what I think you're presenting with. This is what I think you're struggling with. This is what I think best practices should be right now, because we have guidelines for this. So given your condition, I think we should use this course of action. Now you might say, I don't want to do that. And part of my job might be to try to convince you or come up with a compromise. So, well, let's try something in between, right? Let's try something different. With the clear understanding that the proper way or the optimal way of doing things would have been according to the guidelines. Now, there's situations where the guidelines don't really apply. So, for example, you might have someone who comes in, major depression, and then most guidelines will say you should treat this with CBT, cognitive behavioral therapy. Classic presentation of depression, CBT. I've had patients come in, they have a very classical presentation, the usual presentation of depression, but CBT is not the way to go because what they're struggling with is slightly different. I'll give you an example. So I had a patient not too long ago who found out that her new partner was sexually abusing her daughter. This led to depression. So this is depression, textbook depression.
Mm-hmm.
But what's at stake here is not necessarily the depression, but her identity, her function and role as a mother, how she defines herself. And so we worked on her issues very, very differently, trying to redefine the narrative around how she presents herself as a mother, as opposed to working on the symptoms and the cognitions and the behavior as we normally would with CBT.
Mm-hmm.
But both cases would be depression. And so I've explained this to the person. I said, normally we would do it this way. In this case, I think this is what's happening. So can we consider this other possibility? I think it might be more beneficial to you. And that's what informed consent is, right? So if your physician recommends or your psychologist recommends an intervention, well, your job is to ask why, and his job is to explain. Otherwise, you don't have informed consent.
Are there also cases where, let's say you could go down either route. You could go down the psychotherapy route or you could go down the drug route, let's just say. Are there cases, or is it, I don't even know if it's usually true or not, that the effect of the drug will be faster than psychotherapy?
It tends to be the case for mood disorders.
Okay.
It's definitely the case for anxiety, especially if you're using, quick effect like benzodiazepines, for example. 15 minutes, you just decrease the anxiety. The effects of medication when you're looking at both anxiety and mood, so depression, for example, tends to be quicker, but the mid to long-term effects of psychotherapy tends to be greater. So what happens is that you have a quicker response typically to the medication, but then the sustained change happens through psychotherapy. One of the reasons, we're not too sure why, but one of the reasons we suspect that's the case is because through psychotherapy, you learn skills, right? So you have a long-lasting effect. So the simple way to put this is to say medication has a quicker effect and psychotherapy has a long-lasting effect.
So then in some cases, it might be optimal to do both.
Yes, absolutely. But again, this is a case by case, depends on the condition, depends on the individual. Someone might have, one of the challenges, of course, when we discuss these things is that we fold everything into one big, package of conditions, right? So even anxiety disorders, you have to break that down. Generalized anxiety is not the same as specific phobias, for example. So I might be afraid of cats, dogs, or spiders. Medication is probably not useful in that case, right? So it would be psychotherapy, a long session of psychotherapy with exposure that would do the trick, right? So we have to be careful. Otherwise, we're approaching this as if we were saying, it's a bit like asking, does medication work?
Right.
Well, it does work, but for what and what medication? So you can't treat cancer and diabetes the same way, right? So when you put all these things together, you have to keep these nuances in mind. Otherwise, when we make statements that psychotherapy works, yeah, it does work in general across the board.
Okay. Well, I want to focus now on psychotherapy and to talk about, what would be the most common or I guess popular approaches to psychotherapy today?
Mm-hmm. That's an interesting question for a number of reasons. First of all, we go through fads. And that's unfortunate. I shouldn't say that. It's unfortunate and fortunate at the same time because it does indicate a lot of creativity in the field, which is a good thing. So novel approaches that draw on different existing approaches that might be effective, that's a good thing. There's so many psychotherapies out there. Every decade or so, scientists will go through the literature and identify the therapies that are available. I think the last list I saw was maybe 5-6 years ago, and they identified over 600 types of psychotherapies. Now, they're not all legit. Some of them are quack therapies, and a lot of them are variations of one another, essentially. So in general, we think that the way we approach this is that there's four big categories or families of therapies. There's what we call the psychodynamic and psychoanalytic psychotherapies that are basically come from Freud's original psychoanalytic treatments, but that have been modernized. We have very, very short-term psychodynamic therapies as well today. So that's been improved.
Well, what's fundamental about that therapy?
Well, that's one of the first, in the sense that, that's where we put words as the core issue, and something, talk therapy comes from that, right? So that's one of the reasons why when people talk about psychotherapy, they often think of the couch still today, right? The Freudian couch. So that's one of the very first forms of, I think, true psychotherapies. Now that's been improved over the years. There's no doubt. So that's the first family. Second family is what we call emotion focused or humanistic therapies. They focus a lot more on emotions, on the relationship. That comes from Rogers' work, but that's also been improved and refined over the years. The third one is systems or systemic therapy, which is basically treating the individual as a component within a system, a family, which is why you'll see this model applied mostly in couples therapy and family therapy. And then you have, of course, CBT, which is cognitive behavioral therapy. Originally, it was just behavioral. And then they threw in the C for cognitive. And now modern forms of CBT also look at emotion. So a lot of these therapies have evolved quite a bit over the years. There's no doubt about that. So those are the four big families. And then within that, they branch out. And clinicians and researchers fine-tune some of these things depending on specific situations, conditions, or disorders to treat.
Okay. So, so you have these different approaches, and I'm assuming that not all psychologists or psychotherapists practice all of them, right?
You're absolutely correct.
Yeah. Okay. So then how does someone who wants to see a therapist find the right one and the right approach?
That's a great question. The first thing is, I think people need to do a bit of homework. So think about what they might be presenting. Google can be helpful for this as long as you use it wisely. If you go to a website, a reputable clinic to find some information, of course you shouldn't just rely on that, but it gets the ball rolling, gets you thinking about what might be happening in your life. Once you have that, you book an appointment with the psychologist, and then you run it by this person and ask them for their opinion. So the clinician should be able, if they're a good clinician, to answer your questions. They shouldn't feel intimidated because you come in with information. They should negotiate things with you, explore things, look at alternatives, other possible diagnoses. And once you have the diagnosis, and once you've explained the situation, the way I like to practice is, and this is not in the way I teach it at McGill, it's not always like this, is I like to ask one very simple question to myself, which is this really a case of a psychological treatment, or is this a case of psychotherapy / counseling? So in one case, the psychological treatment, we're really treating the condition. The person comes in with generalized anxiety or major depression, and we focus on the condition. In other cases, they might have the same presenting symptoms, but we're not going to address it from the perspective of confronting or symptoms or changing behaviors, but in terms of changing the narrative of one's life. So that's a very different way of working.
Oh,
once
how do you decide which one? How do you decide which way to go?
That's a great question. It comes down to the worldview. So some people, for example, will come in textbook depression, and then you tell them about CBT, and they say that just does not resonate with me. I don't want to do the homework. this feels, it doesn't speak to me. I can't connect with the content. I know your best practices recommend that you do this right now, but it doesn't say anything to me. In other words, it doesn't fit with my worldview. And there's cultural differences as well.
Yeah,
So
I'm sure. Yeah.
very important. So, First Nations, for example, tend to have a preference. The data is not all that strong, but it's starting to come out. Therapies that value the relationship through the narrative, talk therapy, the story, as opposed to approaching their situation through the lens of cognitions and behaviors and emotions. So there's nuances like this. And of course, within groups, there's tremendous nuance as well, that, not every individual is the same. It's not because one person has one cultural identity that they're all the same. This does not work like that.
No.
It's
Okay.
case by case.
It'd be really helpful. Can you give sort of a simple, if there is one, a simple example of a condition and how it would be treated by CBT as opposed to, and then, how it would be treated with the narrative approach?
Sure. So, so if we take major depression. So, for example, someone might come in and then you diagnose major depression. So guidelines would say, well, the recommended treatment for major depression is CBT. CBT is broken down into different components. When there's major depression, of course, it tends to be, lack of motivation and so on and so forth. So one of the first things you want to do is implement what we call behavioral activation. In other words, movement. You got to get the person moving, get them to do exercise. The benefits of exercise have been demonstrated over and over again. So that has to be built into whatever it is you do. So you're going to have the behavioral activation. You're going to have a lot of work which can be done in session and or out of session through assignments and homework that's going to focus on processing my worldview, the way I deal with information. So, for example, if I'm feeling depressed, I might tend to catastrophize. Right? So when people are depressed, well, I'm such a failure. I'm a loser. Nobody loves me. The future is bleak and so on and so forth. So we tend to have a worldview. That's what we call cognitive distortions. It's the way we process the information. So part of the treatment is going to be focused on those specific means of processing those cognitions and how we deal with the information, helping the person come to a more balanced view of things. So for example, like the plumber came to my house today and he seemed upset. I must have done something wrong. Right? So a lot of self-blaming. Well, maybe it's not, the exact, that's not exactly how things happen. Maybe he was just having a bad day and so on and so forth. Now, there has to be a lot of work that goes into that because when a person is depressed, they're resistant, right? So you have to coach them and change them in that. There has to be, so that's the cognitive piece. The behavioral piece is focused mostly on the behavioral activation, but in modern forms of CBT, there's going to be processing of emotions as well. So what leads to the emotion? What's the cognition? So the sequence of events. So my perception of an event is going to lead to a certain emotion, which is in turn going to lead to a certain behavior, and it becomes a cycle, right? So you unfold this so that people can understand it and come up with alternative ways of both thinking and behaving. So that's it. It's a very clumsy summary, but in some, that's what CBT tends to look like. It tends to be much more structured, with assignments and homework and specific tasks that have to be accomplished. Now, if you work from a emotion-focused therapy, you're going to do something slightly similar in the sense that you're going to get the person to think about how they're processing information. So, for example, I'm going to give you a very interesting story that came up from that was given by a colleague who received it from a patient. And so this patient was walking in the park with her grandmother, and they were both barefoot, wearing sandals, and the grandmother stepped in dog poop in the park. And so the patient was really upset, dog owners should pick up their dogs, and so on and so forth. But the grandmother said, good thing I was wearing sandals as opposed to being barefoot. So a lot of clinicians address this as sort of the parliament voting inside your head, right? So how do you emotionally respond to a situation? So am I upset because I stepped in dog poop, or am I happy because I wasn't barefoot? And so there's learning that has to be done around that. That's the first component. The second component is going back to this therapeutic alliance that you and I talked about just a few minutes ago, is the relationship. So can I help you heal things through this relationship by me being accepting of what you bring to the table, by me being reassuring, by me being validating? So that's the second component. So these are the...
Wait, so can I ask you something?
Yeah, absolutely.
With that second component, does that necessarily mean that the therapist takes on more responsibility for the treatment?
No, the therapist
No?
takes on a lot of responsibility for the treatment in absolutely every model. Absolutely
Okay,
every
okay.
model. The way to approach it is done differently. So a CBT therapist might not focus so much on the relationship between you and me. We're not going to talk about that all that much. We might if there's a problem, for example. Someone who's working from a humanistic perspective, or even more so from a dynamic perspective, we're going to talk a lot about you and me, because the way you relate to me in session might indicate the way you relate outside of session. And that's what we want to understand, unpack, and potentially change, right? So there's going to be a lot of discussion about this relationship between you and
Really?
me. Yes, yes.
I find that so interesting, because it almost seems to me you're throwing in now a whole new factor. Like, you know what I mean? Like, well, what if I have an issue with you? Like, that's all I need in addition to all my other problems.
Well, you know what? If you have an issue with me, I first of all, I shouldn't shy away from addressing it. And that's one of the key things in therapy. I mean, there's got to be transparency in the sense that, you should feel comfortable bringing up whatever you want to bring up. It's a come as you are approach to relationships, right? So if you feel uncomfortable, dissatisfied with my work, you should say so. And if I have the feeling that I'm not helping or that you're dissatisfied, I should be able to bring it up and tackle that head on and have an honest conversation about that. Because maybe we've reached a plateau. I don't know. Maybe there's something I can change. Maybe I said something that was clumsy, that was hurtful. Maybe there's something I need to apologize for. I don't know. But we need to have a conversation about that.
Okay, but I would think that would hold true whatever mode of psychotherapy you're doing, right?
Yes.
Really.
Yeah.
I mean, if I'm unhappy with getting my CBT and I'm unhappy with the way you're approaching it, I need to tell you that.
That's across the board. That's across the board.
Yeah.
Yeah. Just like if you don't like the therapy itself, right? If you say CBT, I don't feel comfortable doing these assignments, doesn't speak to me, then, then we should have a conversation about that. There's no doubt.
And can I just ask you, so, and also, should it be clear regardless of the therapy, and maybe not initially, because maybe I don't even know what I want from it. Maybe I'm just a bit confused, but I know I've got issues and I need some help. But at a certain point, should it be clear what my goals are? I need the goal should be clearly stated. Like, this is what I want from the therapy.
It depends. That's the case in most situations. So there has to be ideally some form of agreement between you and me on the goals.
Yeah.
That's important. That said, there are patients who come in sometimes and say things like, I'm just not happy. I don't know what's going on. I feel miserable. I have nothing to look forward to. And so, of course, you can, the goal is to feel better, right? But that's sort of a vague goal. Other people just don't know what their specific goals are. So it might take a while to define them. In other situations, people are not comfortable addressing the real issues from the get-go. That happens too. And that's perfectly fine. They might want to test me, test a psychologist. Can I trust this person? Can they contain what I bring to the table? Are they going to be, upset with what I bring to the table? And then, so they play it out and they see how things unfold. And then eventually, you learn what they're really coming, and seeking services for, right? But it might take a few weeks for that. So you have to accept that. It's not a business transaction. It's not like you walk in, you say, Doc, I got this problem. I got to fix that. All right. Let's, roll up our sleeves and get to work. It's not like that. It's a slow process. Generally, it takes a bit of time. Generally, we have to learn to trust each other. And then we have to define those goals, but you cannot, I think, have a therapy that's absolutely open-ended, that does not have some kind of goal. Otherwise, it becomes this endless therapy, and you're not being a good professional if you don't have a conversation with this person. You're serving, you're basically being a clutch in this person's life, right? You don't want to do that. You want the person to be autonomous and eventually not need you anymore. So at one point, there has to be a conversation about this, no doubt.
Okay, so this is good because you bring up sort of a time frame, and I want to bring that up. I know that is a very tricky question because, of course, it depends on the condition you have and how much treatment you need. But can you give me some sense of, in this area, perhaps you should be seeing some kind of improvement after X number of sessions, or are there any guidelines around that?
There's plenty of guidelines and there's plenty of data. So, If we look at, for example, the UK, they've done a great job collecting data, populational data on all the services that they offer in mental health. So the average number of sessions is 6. This is across the board. So that includes, like I don't feel well to severe depression to anxiety. So if you calculate an average, a mean, it's 6 sessions. So on average, you can say that most people are happier, are doing better after 6 sessions. Now that's across conditions.
Mm-hmm.
If you
that
look
seems really short.
That's very short, but that's across conditions. Don't forget. So there might be people in there who say, I'm fighting with my husband or wife. I'm just not happy. I don't know how to handle, right? It could be it's a mix of everything. Mm-hmm. When it comes to, depression and anxiety, with a few exceptions, typically we're talking about 15 to 20 weeks. Typically. Mm-hmm. Some conditions, the dying tend to take more time because they have this chronic component to them. We often say that psychotherapy works in 7-session increments. So, for example, you're going to have initial change in symptoms in 7 sessions. In 14 sessions, you're going to have a more sustained change, which is why a lot of therapies are built around a 13, 14, 15 session module, 21 session to have longer lasting change, and so on and so forth. Again,
so there's evidence behind those numbers.
There's plenty
7,
of evidence around
14.
this. Again, nuances, right? So the devil's in the details, right? So if you're talking about a personality disorder, you're not going to achieve any change in 7 or 14 or 21 sessions. And that depends also, again, on what the goal is. So, for example, you might have someone who has a personality disorder, borderline personality disorder, which you cannot treat in 7 or 14 or 21 sessions. You cannot eliminate that condition, but you could make some significant changes in the person's life. For example, decrease suicidality, impulsivity, and so on and so forth. So it really depends also on what you're trying to accomplish. So what your desired outcome is. In general, when it comes to psychotherapy for personality disorders, we're talking about many, many months. Some say for sustained change, 18 months on average. Again, that varies quite a bit. Some are very, very difficult to change. Some are not treatable. Some just go away or decrease in intensity with age, not with psychotherapy. So again, many variations
many factors.
in there. Yeah.
Oh, okay. And also, you're talking about weeks here. Am I to assume that you're talking about once a week treatment? What kind of treatment are we talking about?
Typically, most psychotherapies, this is a very good question because a lot of people, clinicians practice using that model of weekly sessions. You go see your psychologist, they come up with a diagnosis, propose a treatment plan, I'll see you next week, right? For some models, it works perfectly. For anxiety, it works perfectly because typically what will happen between the 2 sessions is you're going to have some work to do. So you need that time between sessions to do that work. And then the following session will capitalize and build on that work. And then that becomes exponential and so on. For other conditions, for example, for depression, unfortunately, a lot of clinicians, when it comes to major depression, still have that same model of weekly sessions in mind. So come in, diagnosis, major depression, here's my treatment plan, I'll see you next week. However, when it comes to major depression, there's plenty of evidence that shows that dosage matters. What that means is that you should ultimately be seeing the person twice a week for major depression as opposed to once a week. And in the end, what ends up happening is that you don't need more sessions by seeing them twice. So it's not like you're adding a total number of sessions. It's the same as if you saw them weekly, but you get a greater effect faster. So that's true for major depression.
What about, I know someone who sees a psychologist for anxiety every other week.
Yep, that happened.
Is that effective?
That would be typically, I don't know the case, but typically that would happen towards the end of therapy. So when you do therapy, you're going to have what we call booster sessions or follow-up sessions, and you spread out the sessions. It could be, once every 2 weeks, once a month. Most treatment guidelines would not recommend that from the get-go. It's just not the best way of doing things. You do need some kind of dosage and intensity. That goes for treating anxiety disorders as well. So if you're seeing the person every 2 weeks, you're probably not getting the intensity that you need early on in therapy, at least.
Yeah, and as far as mental health conditions go, I don't know, you have a practice, right?
Correct.
Yeah. So I don't know if you and your colleagues, is a lot or maybe even most of what you see anxiety and depression?
Oh yeah, by far.
By far.
Yeah. Part of that is an artifact of, we're a private clinic. It's not a hospital. When I was at the hospital, of course, we saw more severe cases, very different cases. That said, the cases that we see in private practice tend to be more and more severe. The reason being that people can't have access to services in the public sector. So they turn towards the private sector, private clinics. But usually what we see is mostly when it comes to psychotherapy. For assessment, it's different. A lot of ADD, ADHD, but for psychotherapy, it's mostly depression and anxiety.
And what about the cost? Like generally?
That's a very good question because we don't really know. So I've collected data because I'm at McGill. I do research, and I asked this question 10 years ago, and then we researched it a couple years ago again. So we collected data. The cost is a normal distribution again. So you have people who have sliding scales, for example, who will charge as low as $40 a session, $30 a session. Some people will charge.
Really? I've never heard that.
Yeah.
Okay.
Well, a lot of, there's quite a few clinicians, psychologists who charge the full rate to people who can afford it. And that allows them to have a sliding scale for people who can't afford it. So that's not everyone does this, but quite a few do. The rates vary based on province. There's few psychologists, for example, in Ontario, the rates tend to be much higher than in Quebec. So in Ontario, you can easily see between $225, $325 for a session. That's very common. In Quebec, that's on the higher end of the distribution. It would be a bit lower here. There's also cultural differences here as well. In the English community in Quebec, the rates tend to be higher. In the Francophone community, they tend to be lower, about $25 on average between the Francophones and Anglophones. So there's variations like that.
Can I ask you too, because cost is so important, right?
Yes.
I mean, it could be the deciding factor as to whether someone goes to see a psychologist or not. So because people have to pay, and I'm, assuming they go on a regular basis, that can be a fair bit of money. So right there, I'm assuming it excludes a certain portion of society.
Yes, it does.
Who may very much need a therapy.
Absolutely.
So does that mean then that generally speaking, the people who psychologists see fall within a certain, socioeconomic category? And also, might their issues be different from the people who don't get to see psychologists because of the cost?
I think that's why a lot of psychologists will offer sliding scales. But in general, you're right. I think that what would typically the patients that would be seen in private practice were systemically healthier than those seen in the private sector, in the public sector. And when I say systemically, what I mean is that it doesn't matter what your socioeconomic status is when you have generalized anxiety, it's the same level of suffering. But the complexity of the cases that we would normally see in private practice, they were certainly not as complex as in the public sector. Now that's changing, again, as I mentioned, because people don't have access to services.
You talked earlier about people Google, right? They'll Google things. And I know people who Google things too. Well, you can Google things till you think you've got everything on the planet, right?
Yeah.
And you go into the doctor, it could be, your family doctor or a psychologist, and you say, oh my goodness, look at this. And they have, because I've heard this from other doctors where they're presented with reams of printout of various symptoms and people believe they have it. Well, if that's true for other medical conditions, might it also be true for psychological conditions?
Sure, we see it.
Oh, you do? Okay.
We see it in students. The first time our students in psychology open the DSM, which is the textbook for diagnosis, they say, oh no, that's me, that's my mom, that's my dad. So that, of course, that happens, right? I've seen people come in, of course, and I think this is fairly common, come in with, self-diagnoses. That happens quite a bit. And then you can help them, understand whether, it might be accurate or not. In some cases, it might just be an indication of someone who's anxious. And so what's being treated is not necessarily the conditions they bring and that they printed from Google, but the anxiety. So I've seen many cases where the person has some form of severe anxiety, a fear of diseases and medical conditions and so on, and fear of dying. And they come in, they've printed pages and pages of index medicus from Google and whatnot in the DSM. And they say, well, I have all these conditions and I think this might be cancer and I feel this lump here and I got this and I got that. And so what you're really dealing with is anxiety. And so that's what you treat in that case.
Well, yeah. And it also makes me think too, I mean, if you go on social media, it seems like almost everybody has ADHD.
Yeah.
What is going on with that? And why ADHD? And like, why do you think this has happened? What is the focus on ADHD?
Well, I mean, ADHD is part of it, but I went a couple of years ago. I brought my son to a concert. I won't tell you which one. It's embarrassing. And we were waiting in line, and this young woman was standing behind me, about 20, and then this young man was standing next to her, and they were obviously there, alone individually. And at one point, they turned to one another, and one said, "Hi, my name is George. I have ADD," and she turned around. She says, "My name is Lucy, and I have BPD." And I thought, what a fascinating way of relating to others, right? It's absolutely fascinating. So self-diagnoses, I'm not on social media much, but my daughter is, my son is, and they tell me and they show me some of these things. Self-diagnosis is through the roof. Everyone's looking to, I think, explain to the world or say to the world how special and unique and how much affection they might need, and perhaps express a need to be coddled to some extent. A lot of people express themselves through these diagnoses the same way. Maybe in the 80s and 90s, you had, the goth style, and you had the emo style, and so on and so forth. Now it's through these diagnoses. ADD, ADHD, you have to be careful though, because for the longest time, the kid who was disruptive was just that annoying little brat. That's how they were perceived, and that's how they were treated. And so, and the kid who had trouble focusing, the way we responded was, well, just focus and work harder. We didn't understand ADD. We didn't understand ADHD.
Or give them Ritalin. Oh, let's just give them Ritalin.
And so, we missed many, many diagnoses. When I was back in school, there was no such thing really as ADD, ADHD. It was just a troubled little annoying kid in the back, or someone who's not working hard enough. So that's absolutely terrible, because that shapes the way you see yourself, as a child, exposed to multiple failures. So we have to be careful about some of these things. I mean, the prevalence of ADD, ADHD, it's around 4, 5, 6% adults. Same thing about with children. It changes not so much because of a higher prevalence of the condition, but probably because we're better at picking up on it now. Do we pick up on too much of it? Maybe. I mean, there's a whole, movement, and there's a lot of talk about neurodivergence.
Yes.
There's some value in that. I think sometimes we do take it too far. But again, these are empirical questions. We got to do the research and find out, right?
Who should be a therapist?
Well, different provinces have come up with their own definition in terms of requirements. But what you're asking is more in terms of personality.
Yes.
That's
yeah,
a
because
good
you know
question.
what, this whole interview, like this whole conversation we've been having, and it's so complicated, right? I mean, behavior is so complicated. And then you've got this relationship, and you talked about how important that relationship is between the person and the therapist. So then it makes me think, what kind of person gets to be a therapist, should be a therapist, or shouldn't be a therapist?
Oh boy, oh boy, oh boy. That's a bit, you can laugh here. Okay. I think you need some interpersonal skills.
Yeah.
I hate saying this, but again, it depends. So I'm going to give you an example. I had a colleague at one point who was not very gifted interpersonally, very anxious. But when it came to treating anxiety disorders, her outcomes were spectacular. So it seems that in her situation, there was something that was perhaps unique that allowed her to be very effective in treating certain anxiety disorders, regardless of her, I guess, limitations interpersonally. In general, I would say you need interpersonal skills. You need to be sensitive. You need to be extremely curious. You need to be very accepting. This is one of the challenges. I'm going to go off topic a little bit here that I see, at least in the students now, is that there's a lot of discussion in our society, but especially in universities, about censorship, and this idea of harm, right? And so, a lot of students misinterpret that, don't fully understand it. And it gets to the point where being exposed to someone's thoughts, which might sometimes be very, very messy and upsetting by any standard, to them is unacceptable. So how do you deal with that? Do you shame the person for their thoughts in the name of social justice, for example, which is what these students believed? Or do you accept the person with their anxieties, their worries, their biases and work it through, try to understand what it means, hopefully accomplish some change and try to figure it out with them and with this idea that they come as they are. So that's,
that's really interesting.
That's very interesting. And I see in the young
yeah.
clinicians this inability to tolerate this, because they have this sense of, I guess, moral righteousness. And that makes it complicated because
that totally complicates it.
And,
well, how much of yourself are you supposed to bring into therapy?
Well,
how much of yourself?
It depends. Not all that much, but it's more a matter of, what's acceptable for me as a clinician to hear. I mean, it's gone to this whole censorship we see now in the States. Luckily, it hasn't happened in Canada yet, but in the States, we have clinicians who now advertise in their listings their political position so that patients can choose someone who has the same political affiliation so that the patient can feel comfortable talking about issues. So, if I'm a Republican or a Democrat and vice versa, I want to make sure I'm not going to be shamed by someone who's a Republican or a Democrat. It's gone to that point. We're not there yet. I hope we're going to, things will improve, but we see this in students. So to answer the question, you have to accept that life is messy. People have horrible thoughts. They have horrible behaviors. Our job is to welcome that, try to understand it, and hopefully change it. So you can't shame. Shame never changed anyone.
No. So, oh boy, that's a whole area. I didn't know that they were, specifically advertising that way. But it because part of me thinks, well, if the therapist feels so strongly, then maybe they need to remove themselves from that situation and not, and advise the person to go see someone else if they feel that strongly. But then I think, but part of the job of a therapist is to try to remove yourself from making judgments like that and to be accepting of people and to help them. And if everybody thought that way, well, then who's going to help the murderer?
Exactly.
Who's going to help? You know what I mean? If you take it down the scale here,
Oh, absolutely.
We say, oh no, well, murder, that's the last straw where there's no way I'm going to help that person.
When I started my career, I worked with sex offenders and with pedophiles. And the things you would hear, I stopped when my daughter was born, right? So I just couldn't bear it. But at the time, the things I would hear were absolutely, absolutely horrible. I've had people, I was working in the prison system, a federal prison, individuals saying, I'm just doing this therapy, for example, for sex offenders because it allows me to shave off a few months from my sentence and I'm going to get out of here and I'm going to be smart next time. I won't get caught. So they haven't learned anything. They're not going to change anything. So you can expect this person to certainly relapse. And you would hear things about the way they perceived little boys, little girls, grown women, and so on and so forth that were absolutely offensive. But it was my job to hear that and work it through. It came a point where towards children, I couldn't hear it anymore. So I removed myself when my daughter was born. So I think that's the rule. I think our job is to not shame. It's to accept most of this. There are times when things hit home. They're too close to home. You may, as a clinician, have a certain history that exposes you or makes you sensitive to certain dynamics. Maybe then it's time to remove you and not treat those individuals. But you certainly cannot shame individuals or impose your political views or your worldview. You should welcome what they can bring as much as you can. And if you can't deal with it emotionally, well, you explain it and you find somebody else who can do it.
I just want to end off though, going back to the person who may be looking for treatment. Can you just end off with any advice for people? Like they've been listening to all this and they're kind of on the fence about it. What do you suggest?
I think they should not hesitate. You can at least, you can negotiate with the psychologist. You can say, can I have just a consult over the phone? Let me explain to you what's happening and you can tell me what you think, right? So a lot of psychologists will agree to do that. It's not going to cost you any money. It's going to cost you maybe a bit of time, 20 minutes, but at least you get some information. Ask questions. Once you go in there, don't hesitate. Ask questions. You're allowed to ask questions. You're allowed to negotiate. The psychologist or the psychiatrist or the GP, they're not God Almighty. They don't have answers. They're human beings. They make mistakes. You're allowed to confront them on things. You're especially allowed to tell them that they're not being helpful, that you're not satisfied, that you feel that you've plateaued. These are honest conversations, and a good clinician should be able to hear that. If they can't hear it, leave. Find another one. I think a good clinician will be able to hear that and be receptive and have a conversation around it. So again, the importance of absolute honesty, the importance of words, saying things, you should feel comfortable saying what you think. And so that goes for being happy, and that goes for being dissatisfied with services just as well.
Oh, wow. I thought it was super helpful, Martin. I really enjoyed speaking with you.
It was fun.
Yeah. Thank you so much for coming on with us.
Thank you so much.
Thank you. That's Martin Drapeau. He is a clinical psychologist. He's also a professor of counseling psychology and psychiatry at McGill University. And if you'd like more information on Martin and his research, please check out our show notes. That is it for this edition of the CRAM podcast. You can follow us on social. Our handle is @CRAM Ideas. Thanks for joining us. See you back here next time.